So it is my pleasure to introduce Shirley McGough. Dr. Shirley McGough is a highly experienced academic and currently serves as the Director of Work Integrated Learning at the Curtin School of Nursing. She also holds a joint appointment as research consultant with the Centre for Nursing Research at Sir Charles Gairdner Osborne Park Healthcare Group. Dr. Shirley McGough has a strong background in curriculum design, development and implementation in tertiary education. Her research interests include cultural safety, educational research, and mental health, with a focus on qualitative and mixed methods approaches. She has published extensively in high impact academic journals, and her work is internationally cited, highlighting its global relevance and influence. So thank you for being here today, Shirley. And you can get started on your presentation.
Thank you very much. Thanks for the introduction. Yes, my name is Shirley, and as the title of the presentation suggests, a white woman's perspective. I come to this conversation as a white Western woman, and I recognise that my perspective is shaped by privilege, but also with a deep commitment to listening, learning and advocating for change. So this presentation is not about speaking for others, but using my voice to support a more inclusive, respectful and culturally safe health system. So today I'll explore what cultural safety means, what it matters, and how we, particularly those of us from dominant cultures, can be allies in creating healthcare environments that are not only clinically safe, but also culturally safe. So let's begin, and thank you, Tana, for the acknowledgement of country. I was up in Larrakia country last year, and it was beautiful. I was up in Darwin, and it was lovely to be there, and I hope to be able to go back. I also pay my respects to the traditional owners of the land from which I'm coming from today. That's Perth, Western Australia, or the home of the Noongar people. And I just wanted to share with you some local Noongar knowledge about seasons. And, you know, we can't often follow the seasons that have been put to us from the West perspective of summer, autumn, winter and spring. There are quite unique patterns and weather cycles here in Perth, and I'm sure you experience the same, and quite often doesn't fit those notions of the four seasons. The weather here is very different, and the seasonal changes you can sense those changes depending on the way the plants flower and the way the reptiles respond, and the ways that the swans molt. And all of these are helpful indicators that the traditional custodians of the land, the Noongar people, understood for many years, and they have shared this wisdom with us. So we are in the season of Makaroo, traditionally around June to July, and first rains in the season of fertility. It's a bit overcast here today, and last night we had a really big downfall of rain, so yeah, keeping true to that description. It's usually the coldest and the wettest part of the year with gales and storms, so we had a storm last night, and we're expecting another one tomorrow. During the season, Noongar people moved inland from the coast to the Darling Scarp, or the hills, to take shelter from the harsh coastal winds. And fire was very important during this time, and people would carry branches of bull banksia beneath their kangaroo skins as they travelled. So I'm fascinated by the 6 Noongar seasons, because they really reflect what we experience here when it comes to weather and climate changes. So I would like to share with you a bit about cultural lens. I think we have to talk about cultural lens before we talk about cultural safety. Sorry, but before I do that, I'll just give a bit of history, you know, why I'm presenting today. Tiana approached me probably earlier in the year when she was getting ready to plan the year, I guess. And she approached me to present based on one of the published papers that we have on cultural safety, well, why cultural safety matters. This was within the Contemporary Nurse Journal. It was a special edition looking at cultural safety, and we were fortunate to have our publication included in that. And so my colleagues, we came together. There was 4 of us here from Curtin University, and Professor Rhonda Wilson is from the Eastern States and an Indigenous person herself. So we collaborated to present our thoughts around cultural safety and why it matters within health. Oh yeah, I'd like to get a feel for your profession. I'm a nurse. I understand that there are nurses and potentially other disciplines within the audience. So what is your profession? Can you, I don't know whether you can, it's going to be one of those days. I tested this, of course, beforehand, and it did work, but I guess something happens with Zoom when you're presenting and it doesn't give you the QR code. But maybe you can shout out and hopefully I can hear. What's your profession? Are you a nurse? Are you a medico? Are you occupational therapist? What's the feel in the room?
Did you get that, Shirley?
No, I didn't.
We've got researcher.
Right?
We've got researcher.
Yes, good.
We've got nurse online.
Right.
Nurse online again. Another
Right.
researcher.
Okay.
Another nurse online.
Okay.
Aboriginal health practitioner.
Okay, great.
Physios.
Okay, fantastic. Okay, good. So I apologise in advance if I default to nurse, but I'm talking about health professionals in general. I will try and remember. So first about cultural lens, and I think we need to talk about cultural lens before we talk about cultural safety, and that helps us to understand why understanding our cultural lens is so important when it comes to cultural safety. So culture is at the foundation of people's perspectives of health and well-being, and as health professionals, our relationships with people are influenced by our own cultural lens. So our cultural lens refers to our own personal background, our experiences, our beliefs and values, and shapes how we perceive and interact with people around us. Our cultural lens influences our understanding of behaviours and practices and intentions, and often really subconsciously. So in the context of working in health, we need to be aware of our own cultural lens because it helps us recognise potential biases to assist in providing care that is respectful and sensitive to diverse cultural perspectives of our patients, but also people we're working with. So I want to share with you my cultural lens, the way in which I view the world. My background is Irish and Scottish. I was born in Dublin. My father was Scottish. I grew up in Australia, mostly in WA in the 1970s, 80s. As I mentioned, I'm a nurse. I'm a mental health nurse. I'm a Curtin academic. I'm a mum. I'm a granny. I'm a woman. I work full time. I'm a friend, hopefully. I'm a carer and I'm a cancer survivor. So I'm also a consumer of the healthcare system. So the way in which I view the world and relate to people is shaped by my background. And this is a bit of imagery that I got from AI, which is meant to represent me and my background based on those things I put in. I think that's a little nice reminder that we are viewing people through a lens, and quite often, like the stained glass lens, that can have many elements to it. So Slido isn't going to work here again. But what do you know about cultural safety? Put up your hand if you're really confident in cultural safety and understanding what it means. Put up your hand. All right. Put up your hand if you're somewhat confident. No? Put up your hand if you're not confident at all. And what about people who haven't heard the term, so that's why they're here today? And that's okay, it's a process of learning. All right, so why is culture important when it comes to healthcare? Culture is really important in healthcare because it shapes how people understand health and illness, treatment and healing. It influences behaviours, how we respond to illness, and how we believe it should be treated. It affects communication, the language that we use, non-verbal cues, are all defined by culture. Culture also affects our relationships with people, and also how we may access healthcare when we're unwell. So the nature of Indigenous and First Nations people, particularly around the interpretation of health and well-being, is poorly understood by coexisting Western societies, and this obviously has a negative effect and contributes to the significantly poorer healthcare outcomes and healthcare burdens faced by Indigenous people worldwide. So when we talk about Western-centric views, we're talking about why culture is important. It's because we need to understand the impact that a Western-centric healthcare system has on people who don't necessarily share that same view. So Western-centric healthcare refers to healthcare systems and practices and beliefs that are primarily Western-based, American, and based on medical traditions and values. The limitations with a Western-centric healthcare system and the predominance of a Western-centric healthcare system is that it is very biomedically model focused. It emphasises biological factors in diagnosis and treating illness. It often prioritises medication, surgery, and technology. It tends to focus on individual responsibility for health and can often overlook the role of community, family, and social determinants of health. Excuse me. There's a limitation of standardisation of care based on evidence-based practice. So there tends to be a reliance on clinical trials and scientific research using standardised protocols and guidelines for treatment and approaches to health. There also tends to be these professional hierarchies. Doctors and nurses and other healthcare workers are seen as the primary decision makers and the ones that know best. And there can be a real cultural blind spot which may not consider or respect non-Western health beliefs and practices, and this can lead to misunderstandings or mistrust, especially amongst non-Western groups. Sorry, I'm just trying to work with my other screen. So the critics argue that a Western-centric healthcare system marginalises other cultural approaches to health. It can lead to misdiagnosis, mistrust, reluctance to access healthcare, and timely access to care. So when people do access care, their symptoms are quite chronic or quite severe, and the outcomes or the trajectory of their illness can be poorer than others. It can be unsafe care, discrimination. So in a nutshell, this Western-centric view can be quite culturally unsafe for people, particularly Aboriginal and Torres Strait Islander peoples who may have different understandings and views of well-being. When cultural safety is not present, ethnocentrism prevails, and it restricts us from engaging appropriately with people, as I said, leading to alienation and misdiagnosis and unsafe care. So while Australia's healthcare system does rank pretty highly internationally, there continues to be this gap between health and wellbeing of Indigenous and non-Indigenous Australians, and it remains unacceptably wide across all health statistics. We know that Indigenous people experience poorer physical and psychological outcomes, and this continues to be affected, and obviously this has been the result of the consequences of colonisation, racism, discrimination and intergenerational trauma. So past historical experiences coupled with personal experiences of racism and discrimination and unsafe care can contribute to mistrust in the healthcare system and unwillingness to engage. So several frameworks have been proposed over the years to address cultural diversity and health disparities, including cultural awareness, cultural sensitivity, cultural competence and cultural safety. CAPTANAM, which is the Congress for Aboriginal and Torres Strait Islander nurses and midwives, see cultural safety as extremely important in the professional roles of nurses and midwives, and they consider it as critical as clinical safety. It's important to highlight that cultural safety is not about cultural identity or ethnicity or traditions. It's about the culture of power, which really forms the fundamental philosophy of cultural safety. It's the recognising the disparities and also the power dynamics. We'll talk about that in a few moments. So CAPTANAM views cultural safety as the final step on a continuum of care that includes cultural awareness, sensitivity, knowledge, respect and competence. So I'm not sure if you know, but the concept of cultural safety is not new. It was derived in the 1980s from a nursing perspective in New Zealand to address the retention issues of Maori nurses and the poorer health status of New Zealand's Indigenous people. The pioneer of the concept, Dr. Ramsden, asserted that nurses needed to understand their own culture before attempting to understand other people's culture, and encouraged nurses to reflect on their own culture, values and beliefs to better understand cultures from their own. So cultural safety considers the perspective of the patient, or the person with the understanding of power differences and personal biases. And that's the real, clincher when it comes to cultural safety and how it differs from cultural awareness or competency. People my age, when we did our nursing, we didn't hear these terms, cultural awareness. We were taught transcultural nursing, and we looked at ethnicity and people's perspectives in that way. But again, that's not cultural safety. That's not the foundation of the concept of cultural safety. The essential feature of cultural safety includes understanding your own culture and acknowledge the differences. And as I said, that it is informed by the theory of power relations. It's not political, and also it's defined by the person receiving the care and not by the carer. So what is cultural safety? Cultural safety is about creating an environment that is safe for people. It means that there is no assault or challenge or denial of their identity or their experience. It's about shared respect, shared meaning and knowledge. It's about learning together and truly listening. It includes recognising unconscious bias, racism and discrimination. It includes not only ensuring that the environment is safe for our patients and significant others, but also safe for Aboriginal and Torres Strait Islander people working within the services. So for those of you who are health practitioners and are regulated by AHPRA, our Australian Health Practitioner Regulation Agency, we have a shared code of conduct. There are 12 boards that come together under AHPRA based on our disciplines, and they have a code, and the code describes the professional behaviours and conduct by which we as registered health practitioners are meant to work towards. And within this code that is shared by all health practitioners is cultural safety. So we as registered health practitioners have a responsibility to be familiar with this and apply this to our practice because it's written in our code. Culturally safe practice is the ongoing critical reflection of health practitioner knowledge, skills, attitudes, practicing behaviours and power differentials in delivering safe, accessible and responsible care free of racism. So I've included those two links there. They are there in our codes. And as I said, cultural safety has now been adopted and embedded into AHPRA code, but for us who are nurses or midwives, it's also embedded in our nurses code. The code of conduct, according to AHPRA, says that to ensure that we are providing culturally safe care, we need to understand that it's only our patients or their family can determine what is culturally safe and respectful. In order to practice culturally safely, we must respect the diversity and respect experiences. We must acknowledge cultural and historical factors influencing health at an individual level, a community level, and a society level. We must adopt practices that avoid bias and discrimination and support an inclusive environment and create a positive environment that includes role modelling. And I think that's really important as a health practitioner, that we're role modelling good, safe culturally safe practices to the up and coming generation. So as I mentioned, you know, if you're a nurse or you're a midwife, cultural safety is also embedded into our code of conduct nursing or our code of conduct for midwifery. And there is actually a definition there within the glossary, which again reflects the AHPRA's code of conduct, but also in terms of a relation to Aboriginal and Torres Strait Islander people, cultural safety provides a decolonising model of practice based on communication, power sharing, and acknowledgement of white privilege. So many of us working in mainstream mental health services, which are dominated by these Western-centric views, they may not align with the values of others. And as I said, this alignment can lead to mistrust, misunderstandings, and culturally unsafe care. So why does this matter? Well, it matters because for Aboriginal and Torres Strait Islander people, that should be good health. I've chopped the word out. Good health is a holistic concept that includes the physical, social, emotional, and cultural and spiritual well-being of the individual and the community. And the social and emotional well-being is the foundation of physical and mental health.
Which one?
Sorry, just get some feedback there. And obviously is influenced by the social determinants of health and also the impact that colonisation has had. Also institutional racism that continues, and also ongoing events that occur in society. So I wanted to share with you some research that
Holy shit.
have done. Someone's got their microphone on. You might like to turn it off. That I did a few years ago. It was about how health professionals actually take this concept of cultural safety and apply it in practice. Now, when this study was conducted, cultural safety, the term cultural safety was not embedded in our code. It was a term that it was out there being used, but I don't think it was widely used. And it was several years later that it became headline news when it was embedded into our code of conduct. So this study was aimed to look at how mental health practitioners in particular provided, or how they felt they provided culturally safe care within mainstream services. It was a grounded theory, don't get bogged down on that, it sounds very boring, but it was really just to develop a substantive theory that explores the provision of culturally safe care in a mental health setting and identify factors that inhibit or facilitate the experience of those providing the care. So this is from that article there, lots of colours there, but the basic things I want to talk to you about were what they call in grounded theory the core category, or the basic social psychological problem that people experience when working with Aboriginal or Torres Strait Islander people, was that they felt unprepared. So in grounded theory terms, they talk about the problem. I don't like the term problem myself, but it's the core issue. What was the core issue, the core experience? And people felt very unprepared to look after or work with people, Aboriginal or Torres Strait Islander people. And this resulted in a hesitancy to work with Aboriginal people. They second-guessed themselves. They really didn't know what to do, didn't know what to say. And the things that influenced that feeling of being unprepared were prior exposure to Aboriginal people and culture. So a lot of people that come to Australia and certainly come to WA to work as nurses or other health practitioners are coming from overseas, so they're not aware of history. They're not aware of Aboriginal history. They're not aware of of the past traumas that happened. Obviously it wasn't taught within their schooling. And when they immigrated, they're certainly not prepared for that as well. So they felt really overwhelmed when they came to Australia, and then they were confronted by all these complex issues. People who grew up in Australia, like myself included, we were at school, I'm talking about, primary school and high school, we didn't learn a lot about the history of Australia or the truth about colonisation or, traumas that people had experienced. And certainly that wasn't the focus of my undergraduate nursing training. There were a lot of assumptions people had about Aboriginal people and culture, assumptions about how they expressed themselves or didn't express themselves. People didn't understand what cultural safety was, and they didn't feel very well supported in providing culturally safe care or working with people. So as part of this theory, as part of this research, I also looked at how people overcame their core concern, which was being unprepared, and the experiences that came along with it. People felt very destabilised by feeling unprepared. People consider themselves competent health practitioners, but they felt very unprepared to provide care. And when they did get an insight into the complex needs of Aboriginal people and the gaps in healthcare outcomes, and the complexities and the racism and discrimination that they saw at an individual level and at a systemic level, they had these fluctuating emotions. They felt all the fear and anxiety, they felt shame and guilt, and they also felt defeated. Like, it was a huge problem. They felt unprepared, they didn't have support, they didn't have the knowledge or the resources to provide culturally safe care. So here's some of the direct quotes that came from some of the participants. I don't feel confident. I don't think I'll ever feel prepared. I think that was a bit sad then. As I mentioned, there was this disruption and fluctuation of feelings when people realised that they actually were unprepared, and they sort of made comments. As I said, they felt sad, they felt shame, and when they recognised the truth about the impact and the ongoing impact, they again felt quite defeated. And this was a quote from a nurse who had come from overseas, and he, like many others, didn't have the knowledge around the history of Australia, and he had an interest in Native Americans, and he was quite shocked to hear that that some of the things that had occurred were recent history, and people living today had lived through these traumas. In addressing feeling unprepared, people did a few things to try and navigate the journey of becoming a culturally safe practitioner, and I just wanted to talk to you about a couple which probably were addressed within that paper, Why Cultural Safety Matters. because they were challenged emotionally, because they felt unprepared, some of the things that they worked through or didn't work through was neutralizing the differences. They sought to stabilize these emotions by neutralizing the difference. And this included a range of behaviors that sought to counteract or counterbalance the negative feelings they were experiencing. And they did this through avoidance, minimizing the differences and denying the need to change. So this was some of the comments that they made. They said they might be aware of diversity, but it doesn't affect their interactions. People are human, we care for them like anyone else. Sorry, moving on to the next one. Minimizing the difference, mental health problems are mental health problems, they're the same for everyone. People cope, well, they cope with their life problems regardless of their background. Denying the need to change. I've always approached people exactly the same. I don't think I'll ever approach any cultural group different. It's like treating everyone else the same. So this approach was used to minimise, as I said, their feelings of feeling uncomfortable. But while this colourblind approach may seem a viable option to take or to reduce discrimination by treating everyone the same, regardless of race or culture, it actually encourages a framework that either intentionally or unintentionally avoids and minimises racial inequalities. It also invalidates people's experience. It disregards cultural perspectives of health and wellbeing and treatment. It perpetuates inequalities and it promotes ethnocentrism. So even though people had taken this neutral stance because they saw it as not being discriminatory, they actually were further perpetuating culturally unsafe care. So there's several barriers to integrating cultural safety into practice, and this has come from the research that I've done, particularly the larger thesis. It's about being prepared, it's about managing emotions, it's about managing our assumptions, it's about working with support and working within a system that is doesn't acknowledge its discrimination or racist approaches. So, as health practitioners, how do we apply cultural safety into our clinical practice? Well, first of all, we have to understand what cultural safety is and emphasise the importance it has on making people feel safe and to want to access and engage in care. Our cultural lens influences how we practice and how we build trust and improve connections with people, which hopefully is at the heart of our work as healthcare professionals. Why does it matter again? Well, people's cultural self is internalised and so often ingrained that they don't think about it consciously. So that's important for us as health practitioners, health professionals, that we need to understand that our cultural self is internalised. But also the people that we work with, their cultural self is internalised. And the way that people respond to challenging situations is influenced by their culture. People's instinctive reactions are affected by culture. And again, we're talking about us as health professionals, and we're talking about our patients. So our professional standards outline standards of care that refer to our performance, including our skills, our attitudes, and our attributes. We need to recognise the importance that cultural safety has in providing individual and recovery-focused care. We need to understand the link between trauma and providing culturally safe care. Becoming a culturally safe practitioner is an ongoing journey. It is developed as someone engages a deeper level of self-awareness and critical reflection of our own beliefs, and recognising and accepting the historical treatment of our First Nations people. Why it matters. Cultural safety is consistent with the inherent qualities of caring in our profession. And I'd just like to reiterate that cultural safety is as critical as clinical safety. So factors influencing integration into practice. While principles of cultural safety are gaining traction, they still need to be embedded into tangible actions so that we can embed these actions and have strategies to understand what cultural safety looks like in our practice. As part of our care, we need to appreciate that our healthcare remains very Western in its orientation, and unless prompted and guided, health practitioners will default to what is comfortable and what's familiar and what makes sense to them based on their cultural lens. So we need to regularly challenge our own paradigms to grow our practice of cultural safety, and we need to work with our organisation to ensure that the strategies that they have in place to provide culturally safe care is not a tick box exercise. So what? Now what? I always like to finish up with so what. With the definition of cultural safety now embedded in the Australian Practitioner Regulation Authority and national boards, we need to unite as colleagues and advocates and allies to integrate cultural safety into practice through an understanding with people about what it looks like and how it can be achieved. Cultural safety is essential because it builds trust, relationships and communication, and it recognises diverse world views, and without it people can feel misunderstood, rejected and unsafe. It's only when we unpack our own values and beliefs that we begin to understand our own lens in which we see the world, and for people like myself, recognise privilege as it exists today. Culturally safe care and services are essential to addressing health, improved healthcare outcomes for people, recognising that there's no health without cultural safety. If you are a nurse here in Western Australia and you work at Sir Charles Gairdner or Osborne Park Hospital, I invite you to participate in some research that we're doing at the moment. It's looking at nurses within this particular health setting service and how they provide cultural safety. Again, sort of continuing the work of what it looks like, how we know what we're doing is culturally safe, and how we take those principles of cultural safety and embed that into our practice every day. This is a study I would like to scope up and include other health sites around Australia, but we're starting here at the moment. Again, those two articles I was mentioning, Here's a couple of more that have been published on cultural safety by myself and others. And just to summarise and finalise, I believe this is a group of champions, and looking at the definition of champions, Cambridge Online Dictionary says that champions enthusiastically support, defend or fight for a person's belief, right or principle. So hopefully the take-home message for you today is, as a champion, how are you planning to support, defend, promote or practice cultural safety in your own setting? So that's all I have to present. They're my contact details, and I'm happy to answer questions or take comments.
Thank you so much. I just wanted to share my appreciation for you coming in today. So yeah, thank you. As Shirley said, before we wrap up, did anyone online or in the room have any questions? I have a question. Shirley, what a lot of what you said is what we do in our project. Completely relevant, really important. And I wanted to ask, so what were some of the turning points that led you to want to research cultural safety as a non-Indigenous person?
Yeah, sure. Yeah. Yeah, I spoke once many years ago, you know, what's a white woman doing here, along those lines. How I got into it? Well, I was working at Curtin University many years ago, and my supervisor at the time, Professor Diane Winaden, received a NHMRC grant and it was building mental wealth, that was what it's called, and it was a strategic grant that was looking to build capacity of Indigenous and non-Indigenous academics in building better mental health outcomes for Aboriginal and Torres Strait Islander people. So I was looking at getting into my PhD, and she said, would you consider joining this group as support? There's lots of different projects going on. Is this something that you might be interested in, as an up-and-coming researcher? So I was invited into this group of Indigenous and non-Indigenous researchers, and so that's I got support to do it from my supervisor, but also I got the cultural understandings from the people within the group as well, and that they really helped me form my underpinning questions and how to frame the questions and aims and objectives. So that was done with this group of Indigenous academics and researchers, as sort of cultural consultants, if you like. So that's really how I got into it. Why they stayed in it is probably another good question, and that's because I see it as a responsibility to, I went through some self-actualization, because again, I realised when I first started researching in the area that I had to go back. I had to do readings. I had to read the stories about Australia's history, and that became really unsettling for me as well, because I came out here with my parents as a child, and I considered myself Australian because I was naturalised and I had the citizenship papers. So it really destabilised me when I had to then acknowledge the truth about what had happened. So again, I've come to a place now where I I accept and I acknowledge what has happened, but I also want to continue to do my bit. And I think it's just a really interesting area. I mean, that's what keeps me engaged.
Yeah, thank you for sharing. That was yeah, a really good reflection. Thank you. It's really important for others in the room and online to hear as well.
Yeah.
Hey, did anyone in the room have a question to ask? Anyone online? Oh, all right. Well, we're going to finish up then. Thank you so much.
Thank you. And yeah, thank you for the honour and the privilege of presenting to you today. Thank you very much.
Thank you. Thank you. All right. Bye.
Bye-bye.